Great. Well, welcome everybody, and thank you for joining us this evening. My name is Megan Foster. I am a cisgender female, and my pronouns are she and her. And I work for Sport Manitoba. I'm the lead for the Safe Sport portfolio. And this evening, I am joining you from Treaty 2 territory and the traditional lands of the Métis, Anishinaabe, and the Oke-Tishikovan people. I truly love living and working out of Brandon, and I would like to let you all know that I've been actively working on understanding more about what privileges I hold that my family has brought to me and what I in turn will extend onto my family. And I invite you to learn more about the traditional lands you and your family are now calling home. And if you haven't done that before, you can visit native-land.ca and search for your address or town. And additionally, I encourage you to become more familiar with the calls to action from Truth and Reconciliation that are related to you and your areas of interest. This evening, we are joined together through the theme of health and sport. And those calls within the Truth and Reconciliation calls to action are numbers 15 to 24 and 87 to 91. So I do encourage you to learn more about those at the National Center for Truth and Reconciliation right here in Manitoba. So I'm going to put a couple of links in the chat for you to check out those resources a little more. So getting into tonight's presentation, this morning, the Honorable Kathy Cox, Minister of Sport, Culture and Heritage, proclaimed this as National Concussion Awareness Week here in Manitoba. And Concussion Awareness Week is a federally recognized event happening for the first time this year. We've done a great job here in Manitoba of some ongoing concussion work that both the Sport Medicine and Science Council and Sport Manitoba, as well as the Manitoba Adult Concussion Network, have really been working to actively promote. And the Concussion Awareness Week came after an athlete, Rowan Stringer, died from second impact syndrome. Her parents, Gordon and Kathleen Stringer, are tireless advocates for concussion awareness and education. And Rowan's Law Day is something that's recognized in Ontario. And that really became the catalyst for this year's first Concussion Awareness Week. Canada is the only country in the world with national guidelines and sport-specific protocols. And in Manitoba, we are very proud that many of our provincial sport organizations and sport partners have developed protocols and posted those publicly on their websites. So if you aren't familiar with your sport protocol, I encourage you to look into that. And further, if your sport doesn't have their protocol on their website, reach out to them and ask why, ask where it is, get those conversations started, and they can absolutely reach out to us if they've got questions or need some assistance building that. Manitoba's Concussion Working Group is leading the way in Canada in this work.
Sorry, Josh, I think we may have just lost Megan for a second there. We'll just give her a minute to reconnect.
I may have had some technical issues there. I'm just going to pass it right over to Carter. Go ahead, Carter.
Hi, everybody. I'm Carter Wall. I am a just graduated high school student, and I almost call it a retired hockey player. I've been playing hockey since about age 5 to 6. I played Timbits hockey out of Southdale Community Center. I just played my last year of hockey for AA Railcats midget, and I have suffered almost 10 concussions in my career. Throughout all these concussions, it's been difficult getting back into sport after every time, and everyone it makes it a little bit more difficult. But you do truly learn more about your body and how to react to different situations and what it needs. I've been playing hockey almost my whole life, ever since I could remember. I've been watching my brother's games, I've been reffing, and now I've been trying to turn my passion into coaching. hockey's been a big part of my life, and I do understand that I do have to now push my focus into something else, and I do want to give back to my community. It's been hard not being able to play hockey and not being able to see all your friends who are now into the MJHL and stuff. But I do say that these concussions don't define who I am. They don't define a moment in my life. I just have to, now that I'm given it, I have to put it towards something else. And I do, I'm going to put that towards coaching. If I had my team this year, the Windsor Park Royals, I do have to tell people that if you do experience a concussion, you do have to come forward with your coaches and be honest with them about your condition. You have to tell them that what you are feeling and your symptoms, because I know during my career, I've hidden a lot of my conditions. I've hidden a lot of my bad migraines, blindness to light, just to tell them that, hey, I'm fine, I can keep going during the middle of a playoff game. But that's not what this is about. That's about your mind and body. And you need to be able to listen to them and understand that your body knows best about what it needs to do. There is difficult situations where you do have to take time away from sport, but you do get to watch and cheer on your team. You have to listen to yourself and listen to your mind about what you need in that situation. And there is ways to recover and get back into sport. I know that the best thing for me has been to take my time off, come back, go into full recovery mode, and get myself back into sport. Concussions in the community affect a lot of people, not just yourself. It does affect your coaches, your parents, your teachers. I do know that I've taken quite a bit of time off of school from things that I could not do. I couldn't hear any loud sounds. Most of the time the light would have bothered me, but you do have to push through it sometimes. And it does suck for that moment, but it doesn't define who you are. I have been dealing with concussion-related symptoms ever since my last concussion, and for my last 2 or 3. My last year of midget hockey, during my first exhibition game, I was hit and laid out pretty badly. I did take my time off. I took my 2 weeks, and now I'm back to where I started playing just before Christmas. I went down to a tournament in Minneapolis, and that was where I made a bad mistake. I kept my head down. I looked for the puck instead of the man coming towards me, and I was laid out pretty badly. After that concussion, I started feeling pretty dizzy. I had very bad nausea. I went back out for 1 shift, which was to my mistake, because it made my symptoms a lot worse. I had then got taken off by a nurse who was in the stands and was taken off the ice, and I had not played since. I do have to say, though, that coaching will become a new passion of mine, and that I do understand that I can put more good into coaching than for me just to keep playing hockey and get back to my community. Thanks, guys.
Thanks very much, Carter. We appreciate you sharing your story and for joining us this evening. And Carter's going to be joining as well on Wednesday. So he also has, I'm going to just put a plug in for you, Carter, in your debut news career. Carter is going to be sharing his story on CTV Morning Live on Wednesday morning as well. So encourage all of you to check that out. So this evening's presentation is going to be led by Dr. Ellis and Jeff Billeck. And we then will have a panel discussion where we'll put you into 2 breakout groups and have a case study that you're going to take a look at. So I was going to introduce my 2 presenters, but I'm not trusting my internet connection at the moment. So I'm going to ask Jeff and Dr. Ellis to please introduce yourselves as you are going to speak. Sorry about that last minute change of plans, but I'm quite confident that I will throw this and you will catch it, no problem. So we'll pass it over to Jeff here.
Okay, thanks, Megan. So I guess to introduce myself first, I should first thank Sport Manitoba and the Manitoba Adult Concussion Network for inviting myself out as part of the Sport Medicine and Science Council. I'm currently the president of the Sport Medicine Science Council, but my day job here is at the University of Winnipeg as the head athletic therapist for Westman Athletics. I also teach in the Department of Kinesiology and Applied Health within our athletic therapy program here at the University of Winnipeg, and am currently or have finished my master's degree a number of years ago now, 2016, where we looked at reliability of concussions in 9 to 12-year-olds using the child SCAT. So some experience with concussion assessment and management. And maybe I'll leave Dr. Ellis to introduce himself when we get to part 2. But the plan is to kind of go through the case study that we've created, and then I'll backtrack a bit and talk about sort of the process of getting the athlete off the court, onto the sidelines, and into the doctor's office eventually. And then Dr. Ellis will kind of take over from there. And then we are going to have those roundtable discussions, hopefully at the end, where everyone can ask their questions. I am used to sort of running class a little less formally, where everyone can ask questions as I'm talking, but we'll have to sort of save the questions, maybe put them in the chat if you want, so we don't forget them, and we'll try and answer as many as we can at the end. So our case study today is talking about a 16-year-old female who plays basketball. This athlete was elbowed in the face, fell to the floor, and a bit slow to get up. So at the end of the play, the therapist, which I guess I'm it today, and I go out on the court and assess things. They report or they didn't experience any loss of consciousness, and there was no evidence of any seizure. On the court, the athlete was alert. They were able to answer questions, but they did have headache, dizziness, nausea, neck stiffness, and then reported some blurred vision in their right eye. Okay, they're removed from the court, taken to the training room. After the 15 minutes that's suggested by the SCAT-5, they were assessed using the SCAT-5. They didn't give any symptoms of major red flag type weakness, numbness in their extremities, double vision, worsening headache, or obvious neck pain. But the blurred vision sort of persisted. Based on the results of the SCAT-5, obviously they were recommended to stay out of the game after this rest period. And the parents were notified. And they were given a post-injury education sheet, which is outlined on the SCAT-5. And I won't read through all of that. That information kind of goes with them after completing the SCAT-5, making sure they receive medical care afterwards if there are warning signs. And again, we'll talk about that and how the blurred vision maybe fits into our assessment. And then because of the concern with the concussion and the potential facial injury, they were advised to go to the nearest emergency department to be assessed by a physician. Okay, they were seen in the emergency department. They continued to experience all of the symptoms that were listed. And because of the concern, maybe a potential facial fracture, the doctor decided to use CT imaging, and which revealed no evidence of acute intracranial trouble or facial fracture. And then the patient was discharged home to follow up with a physician the following day. So I guess before we talk about the actual process on the field, I really, and after, these guidelines have come out and we've really started using pre-season education, and I use it here with our Westman athletes, it really helps with everyone being on the same page and understanding what process is going to happen as these situations come up. If we don't have this preseason education, there's gray areas in concussion assessment, and we want to minimize those gray areas as much as possible. So we all have to make sure we're on the same page prior to starting the season, and making sure that coaches, athletes, parents all understand what's going to happen should someone receive a mechanism of concussion and show signs or symptoms of concussion. And this is kind of where the concussion recognition tool comes in for me, is where we start with these assessments on the field, because we have to be able to recognize the injury properly. So, and obviously I probably don't need to review this with everyone here, but we'll go through it quickly, that acute concussion should be suspected in anyone that sustains a significant impact. And we're talking about our case here, obviously. She's sustained a significant impact to her face and is showing signs and symptoms of concussion. So they have to be removed from play. And now I'm sort of getting ahead of myself a bit, but when we talk about going onto the floor to assess this person, and I can speak just for athletic therapists here, but I know there's many other professionals that will be assessing people on the field. And I can just speak from my professional training, and everyone's is a bit different. We're trained from a first responder perspective, where we might have to do a primary survey, secondary survey type thing, and make sure there's no other injuries in this situation. In most on-field situations, we're trying to determine their chief complaint and ensure there's no complicating factors or red flags that need an ambulance. So we're thinking of these things as we assess, obviously, and want to make sure we're not missing anything. Obviously, the first rule is to do no harm, and we want to make sure we're assessing safely and effectively. And as with most professionals, we kind of develop a philosophy for care. And in the case of concussion, it has to be sort of from a perspective of caution. We want to make sure, we're dealing with developing young brains. We're talking about youth concussion today. We want to make sure we're handling these things with that caution. So if any of these red flag situations come up, and all of these are listed on the recognition tool that we'll go through in a minute, we want to make sure that we're utilizing EMS in that situation. We want to make sure they're being cared for as immediately as possible. So obviously, I'm just going to go back one here. Before we go on the field, we want to ensure that the scene is safe. So the refs called us on. We're obviously not interrupting the play. If this person was kind of trying to get up, they're kind of unsure, we want to make sure we're able to come on the floor first of all. So, and as we approach the person, we're thinking of that primary survey. So they're alert when we get to them and talking to us, what's their level of consciousness like? Sort of where are they at? And we're starting to rule out these red flags. Do you have any pain in your neck? Is there any other pain anywhere else? Do you have any other problems? What are you feeling right now? Sort of open-ended questions so they can report to us what they're feeling. This way we kind of get that level of consciousness from them as well and see how they respond. So maybe even distracting them. Can you take a big, deep breath for me? They're going to be anxious. They just took an elbow in the face. Maybe they're angry. I don't know how many saw the Jets game last night as Dubois took the cross-check in the face. He went off the ice throwing his gloves down the hallway. That's a difficult situation. Agitation can be a sign of concussion. So where is that in the scheme of what we're looking at? We want to get a picture of what this person is going through. So like I said, this is where kind of the recognition tool comes in. There's no significant neck pain. We've palpated the neck. There's no significant midline tenderness. They didn't really have a mechanism for a major neck injury. If this person had been pushed from behind and went headfirst into the wall, obviously the axial load would be more concerning. But this person doesn't have that. But they are complaining of some blurred vision in their eye. So again, maybe we're going through some palpation to make sure there's no obvious fractures, no blowout fracture, nothing else obvious that we need to splint and protect before we're moving this person around. And then, talking to them, it looks like you took a pretty hard hit. what else are you feeling? Any other pain? Is it just your eye? What? And this is when they've told us they have the headache, dizziness, and the blurred vision. Okay, so mainly sticking to open-ended questions. And really our decision is somewhat made at this point on their return to play. And we'll talk a little bit about the role now that maybe sideline assessment and further assessment has. But what all of these other questions are helping, if this person has major dizziness, nausea, how are we getting them to the sidelines without causing more trouble? We don't want them falling down again. Are we helping this person to the sideline? What does that look like? What's the safest way to get them to the sideline? Do we need help of other athletes because they're too tall for us? Thinking of all of those kind of things. Okay, so this is kind of the process, and this is a very Cole's Notes version of the assessment. I really like in the bleachers comics. Anyone who's been in my classes has probably seen them. I have a 9-month-old lab, so we'll work on what this guy's doing here with him. We'll see if we can train him the way they're training COVID dogs. But since we don't have that, like I said, we're going through the safety process. Can we get on the court? Has the referee called us on? The play's stopped. We're determining that chief complaint, ruling out obvious red flags, and then calming the athlete. Can we refocus them and get them breathing normally, calm them down so that the rest of the team can see that we're calm. We can really disrupt a team's sort of atmosphere in a game too if we create more panic or anxiousness. So we want to make sure that the situation is calm and that we have things under control. Okay, we've determined the level of consciousness and orientation level, which helps us then determine how to get them off the court. Okay, and our sideline assessment. So we need to give them time, as suggested in the SCAT, you know, the 10 to 15-minute break to let their physiology sort of calm down and see what happens, but they need to be monitored over that time. Someone has to be with them. We need to ensure that their symptoms aren't worsening and we're not seeing any of those red flags, worsening headache, vomiting, you know, some of the major signs that we need to get this person seen sooner rather than later. Okay, if there's no concern for the more serious injury, this person needs to be removed, obviously. And then if we're available, we can perform the SCAT or child SCAT. And we can talk, hopefully have a minute or two to talk about some of the difficulties, especially with the child SCAT and kids sort of maybe being less aware of symptoms like this and understanding how they're feeling. So, you know, many adults have had time to learn those symptoms and understand. And it'd be great to hear Carter's opinion on that, maybe when we go in our groups on just, you know, whether maybe he didn't recognize some of the symptoms at times too, and learning more about it has allowed him to recognize, like he said, you know, important for the athletes to recognize in themselves and in their teammates to be careful with these injuries. And that's no blame on the athletes at all. It's just a self-awareness that develops over time. So using the SCAT-5, it's one part of the process. Again, it is not the only tool that we use. The concussion assessment is still a bit more art than science because there's lots of unanswered questions. So maybe this person has delayed symptoms, maybe they're good at hiding their symptoms, and it may come across as basically normal when it's done. So we've got to really use clinical judgment in these situations as well. And again, it just can't be used as the only tool. We've already determined that this person came off with a headache, they sustained a mechanism, so they're out for the game. So now, you know, this SCAT-5 for me kind of allows for a a tool to give us more documentation along the way. So, to me, why is the SCAT-5 useful in a sideline situation? Well, we can use it as part of or the information from it as part of the referral to the physician. I think it always helps to send something with the athlete to help the physician with what's happened on the court. Monitoring their recovery, thinking of later in the process, the athletic therapist can be involved in this. So we know where they were at 7 p.m. tonight when the concussion occurred, and we can monitor now that we use sort of symptom limiting recovery instead of symptom free. We can judge whether those symptoms are recovering or getting worse with what we're doing. And then the SCAT-5 contains a lot of important home information for the injured person and their caregiver. We can give it to them in writing what the return to learn process is, what the return to play process is, what the red flag symptoms are to watch for at home. I think all of this sort of calms the caregivers in knowing what is coming and what to sort of plan ahead or what's going to happen going forward. And then, of course, documentation is a professional requirement, no matter what profession we're in. So it gives us a document to put in their file. Okay, this is an example of exactly what Carter was talking about. In the picture on the left, the snowman is helping out his teammate to recognize he has an issue. So hopefully teammates can do this for each other. I just had this weekend working with our soccer team. One player came to me saying that someone didn't seem right, and I'm really glad that message has gotten through. It really, even though it's happened once so far this season, definitely better than zero. So it was great to see they were looking out for each other in regards to concussion symptoms. So again, most youth sports settings won't have on-site access to therapists and physicians, but if we are those people, if we're coaching or involved in the coaching staff somehow, we have to kind of recognize what our conflict of interest is there too in creating the lineup and putting people back in. This is a tough position to be in. So, and we need to remember that caution, right? That all youth athletes that sustain a suspected concussion need to be removed from play, and let's let doctors like Dr. Ellis determine whether and when they can go back. Okay, and so again, I have this slide up as athletic therapist, but there can be many other health professionals, and I recognize that we're not the only ones. I'm just saying this because that's my certification, and I don't want to speak for others. But this is kind of what I deal with in a regular season, is the preseason education part of things, making sure we're all on the same page for the policy. So this, Basketball Manitoba has a policy on their website. We make sure all basketball players are familiar. We have a Westman concussion policy that we hand out to all the athletes, all the coaches. Everyone's on the same page if this injury happens. And then, understanding our on-field assessment and first aid, right from our first responder training to the on-field assessment information they're getting in class, sideline assessment with the SCAT and the importance of that, communicating with the athletes, coaches, parents, any other medical professionals. That's a big role that we have. And then arranging for the referral, helping them know where to go. Some of the athletes will be from out of town, maybe not from the city. We can help them, or from the area that they're playing the sport in. So we can help them find those. And that's all part of our emergency action plan process. And then lastly, sort of assisting in the supervision of helping the athletes get back to school, sort of the return to learn and return to sport process, and really emphasizing that return to learn process before the return to sport. So that's kind of the quick version of taking the person from off the court to referring them to the emergency room, and then hopefully the emergency room referring them to physicians trained in concussion management. So from here, I'll stop sharing my screen and let Mike, Dr. Ellis, take over. And I'll hopefully be able to answer questions when we break into our groups.
Thanks, Jeff. I'm Mike Ellis. I'm a doctor that works at Pan Am Clinic, also part of the Manitoba Concussion Working Group, and work with the Manitoba Adult Concussion Network. So as Jeff said, I'm just going to kind of continue on with the case here, if I can. So the athlete that we were previously speaking about undergoes a medical assessment by a physician at an interdisciplinary concussion program the day after her injury. On clinical history, she reports she did not lose consciousness at the time of her injury, but did have a brief period of post-traumatic amnesia. She denied experiencing any acute neck pain or focal neurological deficits. And on the first day that she's seen in her clinic, her post-concussion inventory score was 25. On clinical interview, she reported persistent headaches that are localized to the occipital and bitemporal regions of her head, some nausea, dizziness that she describes as lightheadedness without vertigo, sensitivity to light and sound, fatigue, intermittent blurred vision in her eye, in her right eye, and difficulty with memory and concentration. At this point in time, she is experiencing some mild neck pain, but denied any weakness or numbness in her extremities. And she reported that she's feeling more anxious than normal, but denied experiencing any panic attacks or any thoughts of self-harm. Her past medical history is significant for 2 previous sport-related concussions, as well as anxiety and depression. Her last concussion occurred the previous year and was managed by her primary care provider, and she made a full recovery after 2 months of symptoms. She was diagnosed with anxiety and depression approximately 2 years ago. Her medications include fluoxetine, and she has no allergies. She denies smoking or using any alcohol or recreational drugs. She lives with her parents and younger brother and does not play any other sports besides basketball. So her physical examination is a little more comprehensive than what we see in the SCAT-5. In this case, the patient underwent a fairly comprehensive assessment of her vision and ocular motor functioning. She does have some right-sided periorbital swelling and bruising, but her motor and sensory exam are normal. Cerebellar testing is normal. There's some postural instability identified on tandem stance balance testing. She does have full range of motion of her cervical spine with some paraspinal muscle tenderness, but no central spine tenderness. On ocular motor testing, her near point of convergence is 10 centimeters, and her objective testing is otherwise normal. And the doctor reviews the results of her CT head and facial bones, and there's no additional investigations that are indicated. So based on the clinical history and physical examination, the diagnoses that apply to this patient are an acute sport-related concussion, an associated whiplash-type injury, and a soft tissue facial contusion. So the patient's provided with a post-injury education sheet. They're provided education and guidance on how to make a gradual return to school and sport-related activities. They're provided a medical clearance letter indicating which activities they can participate in. And it's recommended they follow up with their athletic therapist for supervision of their return to sport progression and consideration of initiating some manual treatment of her neck for her associated whiplash-type injury. And she's also provided information in case she experiences any acute deterioration in her vision. 1 week later, she's reporting significant improvement. Her PCSS inventory score is 7. On clinical interview, she's saying that she has some persistent neck stiffness that's been responding to treatment from her therapist and has some persistent difficulty with memory and concentration. Her intermittent right eye blurred vision has resolved. She was feeling a little bit more nervous about some upcoming exams, but denied any depressed mood or thoughts of self-harm. She's returned to full days at school without any academic accommodations and was tolerating light aerobic activity and sport-specific activities without any symptom exacerbation. Her repeat physical examination showed some mild paraspinal muscle tenderness, but her exam is otherwise normal and her repeat visual exam is normal. 4 days later, she follows up again. She's reporting that she's back to her neurological baseline with no persistent neck stiffness. Her post-concussion symptom inventory is 2, just indicating some mild anxiety. On clinical interview, she's tolerating full-time school, completed her exams without difficulty, and under the supervision of her athletic therapist has been tolerating low-risk volleyball practice without any concussion-like symptoms. Her repeat physical examination is normal. However, given the history of 3 lifetime concussions, we did decide to refer her for formal neuropsychological testing performed by a neuropsychologist that revealed results that were within normal limits without any concern regarding cognitive impairments secondary to a concussion. So the patient was provided, again, education and guidance regarding her final clearance and steps to return to sport. She was provided with an updated medical clearance letter indicating that if she can tolerate her full practices without any concussion-like symptoms, she can return to games as tolerated. It was acknowledged during the final visit that there's no evidence-based guidelines to direct return to sport or sport retirement decision-making in patients with multiple concussions. But she was advised that given her history, she may be at an elevated risk of suffering a future concussion that could lead to persistent symptoms or a change or deterioration in her mental health. And she was recommended to follow up with her primary care provider for ongoing management of her pre-existing anxiety and depression. So again, carrying on from where Jeff kind of left us, our national concussion guidelines in Canada, both the Canadian guideline on concussion in sport and the ONF living guideline on diagnosing pediatric concussion, both recommend that athletes with a suspected concussion or all children with a suspected concussion should undergo medical assessment by a medical doctor or nurse practitioner. And so in order to provide a comprehensive evaluation or assessment of athletes with acute head trauma, the medical assessment really must identify, classify, and medically diagnose existing forms of traumatic brain injury. It must be able to rule out independently medical or neurological conditions that can present with concussion-like symptoms, and it must be able to identify and medically diagnose and treat coexisting injuries to the eyes, face, neck, and extremities. Just like any other medical condition, the medical assessment components consist of a clinical history, a physical examination, and the supplemental use of tests as needed. The clinical history is going to collect information on demographics, the details about the event, immediate injury characteristics such as loss of consciousness or seizure, immediate symptoms. It reviews the results of previous medical assessment and diagnostic testing. It's important to carry out a fairly thorough past medical history, including previous concussions, length of recovery, any types of pre-existing mental health disorders, medical conditions that are associated with concussion-like symptoms, medications, allergies, histories of substance abuse, social history, and current symptoms can be assessed using a validated age-appropriate symptom inventory. Again, the physical assessment is much more comprehensive than that's included in the SCAT-5. Mental status, a head and neck exam, cranial nerves, motor sensory reflexes, cerebellar, balance testing, gait. With appropriate expertise, the physician can do some advanced ocular, motor, and vestibular testing as indicated. And it's always important to do an assessment of the cervical spine to rule out any associated spine injuries. And there may be some additional physical examination tests that are needed depending on the clinical history. Supplemental tests are rarely used or needed in patients with acute concussion, and particularly in youth. But sometimes we'll use plain film X-ray imaging to image the cervical spine or the face or extremities, CT imaging of the head or the face, or MRI imaging of the brain and the cervical spine. Again, it's important to use validated clinical decision-making rules when you're using these types of tests, especially when they're associated with risks such as radiation exposure. And then in some cases, neuropsychological testing can be used to clarify the diagnosis in patients presenting with acute symptoms that are maybe transient or atypical. And these other tests are tests that we very rarely use in clinical medicine. Again, once you've completed a medical assessment, it's important to communicate the medical diagnosis or diagnoses to the patient or their guardian. Provide written and electronic verbal return to school and sport education and guidance. Provide medical documentation so that the athlete understands what activities they are medically cleared to participate in, and arrange periodic medical follow-up. Again, in general, patients are normally managed with using a return to school strategy, which is essentially a stepwise process, exposing the patients to increasing amounts of school while they're monitoring their symptoms. And again, this which should always take place before returning athletes to sport-related activities. And then we'll essentially walk patients through the return to sports strategy, which again is just exposing athletes to increasing amounts of physical activity and sport-specific exercise while they're monitoring their symptoms. Again, in general, these should be done on a daily basis, or at least be 24 hours for each stage. But this is kind of a general overlay or outline of that approach. As Megan mentioned, we're very fortunate to live in a province that's taken a lot of leadership when it comes to concussions. So our Manitoba government, in particular, the Ministry of Education, has done a great job creating a concussion page on their website. They also provide guidance about which resources should be used, and provide guidance to school boards and school divisions about how to develop a concussion protocol that's harmonized with the Canadian guideline on concussion in sport and our sport-specific provincial guidelines. As always, Sport Manitoba has taken a leadership role in developing our Manitoba Concussion Working Group, and then also leading the provincial sport organizations and helping them to develop protocols for the individual PSOs. And so all of the sports stakeholders, from coaches to parents to athletes to officials, are basically all on the same page when it comes to starting the season. And we're all on the same page whenever a suspected concussion occurs. One of the most notable provincial sport organizations has taken a leadership role in concussion management is Basketball Manitoba, who came up with their own sport-specific return to basketball strategy, which is used in patients that are participating in basketball. And it's available on their very excellent landing page. So basically what we're doing is we're following the patient till we feel that they've made a clinical recovery, which is defined as being asymptomatic or back to pre-injury clinical status, tolerating full-time school without academic accommodations, tolerating non-contact practice without symptoms, and being back to their pre-injury fitness level, having a normal physical examination. Some patients or athletes will benefit from supplemental testing to help confirm physiological or neurocognitive recovery. And return to sport clearance should take into consideration individual patient factors such as injury characteristics, past medical history, and should utilize or be, those decisions should be made in collaboration with their team therapist where available. In this case, we elected to refer the patient to a neuropsychologist for neuropsychological testing. Again, the Manitoba Concussion Working Group has been a leader in trying to develop high standards for the use of concussion baseline testing and neuropsychological testing. So several years ago, we were able to publish these recommendations, which essentially indicate that preseason and post-injury testing, when it's for neurocognitive testing, should only be performed by a neuropsychologist, and preseason baseline testing is not recommended for youth athletes. Again, the role of physicians in concussion management, again, is to provide the medical assessment of athletes with acute head and spine trauma. This ensures that the athletes receive the correct medical diagnosis by a qualified provider. Our job is to oversee medical management of the athletes and provide medical clearance to return to sport activities. As always, it's always easier to manage athletes when you have a great team. And so physicians are always encouraged to work with other healthcare providers to optimize care of their athletes. And whenever possible, it's great to be able to work with many of our excellent athletic therapists and physiotherapists who provide sideline assessment and care of the teams in our province. So for more information about interdisciplinary concussion care in adults, please feel free to visit the Manitoba Adult Concussion Network. And for more information on the provincial sport-specific concussion protocols and sport concussion in general, please feel free to visit the Smart Manitoba website. Thanks again for your attention, and we're going to move on to the panel discussion next. Thanks.
That's great. Thanks very much to both Dr. Ellis and Jeff for that, walking through that presentation. And we're now going to move into a panel discussion. So we have been sorting you into breakout rooms. So each room is going to have a panel of 3 folks that are going to lead through discussions. Before we do that, I'm going to check with Jeff because I can see Jeff. Do you want to take some questions now, or do you want to go right into those panels? What would you prefer?
I think the plan was to go to the panels, but if we have pressing questions, we could probably take 1 or 2 depending on time.
Sounds good. We haven't seen any come into the chat yet. And Josh, correct me if that's wrong. But if you do have questions, please certainly don't hesitate to put those in the chat. And in the meantime, Josh, are we ready to move into our breakouts?